All right, I think we'll go ahead and get started, and I'd like to welcome you to Baylor Scott and White Hot Hospital Plano, and we just want to talk a little bit about our campus program. So my disclosure, I'm a trainer and speaker for the robot that you've seen in the back. So our agenda today, we started out with test driving the robot. This is our physician panel, and I'm Dr. Jett, Dr. Waters, Dr. Kovoor, and Dr. Awad. After we finish this, we'll have question and answer, and then we'll play on the robot some more. And if you didn't get to play on the robot before, it's really fun. You kind of see and appreciate what we do in the operating room. So just briefly, this is an introduction to lung cancer, and then each of us will have our own talk. But briefly, there are 226,000 new lung cases of lung cancer every year. There's a new diagnosis overall worldwide every 2 minutes. There are 160,000 deaths per year from lung cancer. That's the bad news. The good news, there are over 400,000 lung cancer survivors, some even in the audience now. So it is a treatable and curable disease. It is the second most common cancer. Prostate is most common in men and breast in women. It's 14% of all lung cancers, which doesn't seem like much. However, the bad news about that, it's a leading cause of cancer deaths. It accounts for more deaths than all the other cancers combined. And a lot of that's just because you don't diagnose it until it's late. Stage 3 or stage 4 was not really curable. It's still treatable, but the 5-year survival is much less if you catch it in the late stages, and that's why it accounts for so many deaths. There are also some statistics about lung cancer in women. Over the last 41 years, lung cancer has decreased 35% in males. We've done a good job of stopping smoking. However, a lot of lung cancer in women is not caused by smoking, and that incidence has increased 87% in females over the last 41 years. So that's bad news. In women, there's a new diagnosis of lung cancer every 5 minutes. 37%, only 37% of women list lung cancer as a health concern. However, 80% of healthcare decisions about the family are generated by women. So women need to be educated about lung cancer. It needs to be more on their radar. The risk factors for lung cancer, first and foremost, is cigarette smoking. The second most common risk factor is radon exposure. Then you have secondary smoke, occupational exposure, genetics, low-level radiation. There are 2 different types of lung cancer. You have small cell, which accounts for 15 to 20%. Non-small cell is 80 to 85%. Of the non-small cell cancers, you have squamous cell and adenocarcinoma in pretty much equal proportions. Then you have large cell and differentiated large cell neuroendocrine and carcinoid. And this is just a diagram showing you sort of what they look like, with small cell being not that common, adeno and squamous being the most common non-small cell cancers. The symptoms are pretty obvious: a cough that doesn't go away, chest pain, hoarseness, weight loss, blood or rust-colored sputum, shortness of breath, fever of an unknown cause, and recurring chest infections. Many different ways to make the diagnosis, and that's one of the things we're going to talk about in this panel. You have chest x-ray, CT scan, CT-guided needle biopsy, MRI, PET scan, bone scan, bronchoscopy, and EBUS. When you talk about lung cancer, you talk about the staging. The staging is dependent upon the TNM status of it. The T is the size of the tumor, N is lymph node involvement, and M is metastasis. And these are complex graphs, but it shows you that the size is important. The bigger the size, the less the 5-year survival. And that's sort of demonstrated on this diagram. And we go from T1 up to T4, and survival is less as each of them increase. We look at lymph nodes, and we look at lymph nodes within the lung, but then outside the lung, along the windpipe and along the lung, and where things break up. And we have different stations. We have like 12 different stations that are named, and where the lymph nodes are involved makes a difference in terms of survival. And this is the International Association Study of Lung Cancer, the 8th edition, and it's pretty complex looking. You don't need to memorize it today, but it gives you the staging according to the size, lymph node, and whether it's spread anywhere else. And the survival depends on the stage. The worse the stage, the worse the survival. The majority of lung cancer is not discovered in early stages. Only 24% are stage 1, 7% stage 2, over 60% are stage 3 or 4. How can we stage it? You can use CT scan, PET scan, MRI, or bone scan. That's the clinical staging. Surgical staging, you can use bronchoscopy or endobronchial ultrasound, which Dr. Kovoor will talk about shortly. You can do mediastinoscopy, or you can go in either thoracotomy, VATS, or the robot. Different ways to treat it. You can treat it surgically. You can use chemotherapy, radiation therapy, and Dr. Kovoor talk about the chemotherapy treatment of it. You can use ablation therapy, or if it's beyond the treatment stage, then you can do palliative or hospice care. On campus, we have a campus-wide program with Baylor Plano. We have the oncology program at the Charles A. Sammons Cancer Center. We have the Cancer Health and Wellness Center. We have Texas Oncology. We have Dallas Diagnostic Association with our pulmonologist, Dr. Awad, Dr. Kovoor's with the oncology. And then you have the cardiac surgery specialist for the thoracic surgery of Dr. Waters and myself. The Sammons Cancer Center has medical and radiation oncology services. They have low-dose CT screening for lung cancer, which Dr. Waters will talk about. We have a nurse and patient navigator. We have the thoracic robotic clinic, and we have a multidisciplinary thoracic oncology clinic. The Cancer Health and Wellness Center assists patients through their cancer journey. They have a resource library. They have a gym offering Fit Steps for Life. They have medical, psychology. They have a patient navigator to help them go through their journey, genetic counseling, and nutritional counseling. The multidisciplinary thoracic oncology clinic is mainly for patients with stage 2 through 3 lung cancer. And the goal is to assist patients with their cancer treatment options. It's a medical and surgical panel. We meet with the patient and their family. We review the test, we discuss the test, and develop treatment options tailored to the specific patient and family needs. On our panel, we have medical oncology, radiation oncology, pulmonary medicine, thoracic surgery, radiology, pathology, and our nurse and patient navigator to all discuss these issues. That's sort of an overview of lung cancer and what our program on this campus offers. So our agenda, as I mentioned before, Dr. Waters now is going to talk about screening for lung cancer, and Dr. Awad will talk about staging of lung cancer, Dr. Kovoor, medical treatment of surgical cancer, and I'll follow it up with the surgical treatment of lung cancer.
I was asked to talk about lung cancer screening. And I thought I'd show this first. This picture here is of a famous thoracic surgeon named Everett Scram, who was one of the earliest scientists to develop recognize an association between cigarette smoking and lung cancer. What's in front of him are cigarettes, and he found in mice that actually produced lung cancers. Graham was the first to perform a pneumonectomy for lung cancer, and he actually underwent a pneumonectomy because he was a smoker and developed lung cancer. As Dr. Jett said, this is just a cartoon, appeared in one of the journals, showing the incidence of new cancer cases in this country in 2006. And as Dr. Jett had said, in women, the number one cancer is breast, and men, it's prostate. But lung cancer is second in both genders. Lung cancer is a deadly cancer, and this is an updated chart from the American Cancer Society showing how many people die from lung cancer in the U.S., and this was in 2018. And you can see that lung cancer in both men and women really pales the competition. It's just another cartoon from the American Cancer Society. This is a little bit dated information, but when you look at the death rate in the male population and looking at lung and bronchial cancer, really is pretty severe. How do you prevent lung cancer? Well, it's really not till recently they developed a screening test. You know, with colon cancer, you have colonoscopy. With breast cancer, you have mammogram. With lung cancer, there really wasn't anything until the last few years. These are just two diagrams. The one here on the left-hand side is the recommendations from the U.S. Preventive Services Task Force giving guidelines for who should get lung cancer screening. The cartoon on the right is just a little bigger representation of the same thing. But anybody who's aged 55 to 74 with a tobacco history equivalent to about 30 pack years or more, and a pack year is if you smoke 1 pack of cigarettes per day for 30 years, that's a 30 pack year history. And if a patient has quit over 15 years ago, they would not qualify. But patients that fit into this demographic qualify for lung cancer screening. What is lung cancer screening? It's a low-dose CAT scan. Patients will come to radiology suite. The test takes about 30 seconds. And it's not high-resolution CAT scan, so it reduces the radiation exposure that they get and is found to be efficacious for identifying lung nodules. Where did all this come from? Well, it came from probably decades of research that people did. This slide here on the left-hand side looked at randomized controls trials that were done to try to help screen people who had lung cancer. These were done at some of the larger academic medical centers in the country, Memorial Sloan Kettering, Johns Hopkins, the Mayo Clinic. And back before 2000, people would just get a chest x-ray and a sputum sample. So you go to the doctor, you get a screening chest x-ray, you'd expectorate, and they'd want to see if you could see malignant cells in the saliva and whether you see a lung mass. They found that none of those programs was efficacious at identifying lung nodules. CAT scanning became better technology in the 1990s and the early 2000s. And this slide here on the right is a review of papers that people put out showing the use of CAT scan in identifying lung nodules. Over the years, the resolution of CAT scan has gotten better. The technology has gotten easier to use and easier for physicians to interpret. This is an article that appeared from the New England Journal of Medicine that was pivotal in getting the lung cancer screening program developed in the United States. This was a paper that appeared in 2011. And it was a randomized trial of 53,000 patients in the United States. And the numbers here are what you see in that U.S. Preventive Task Force recommendation. So patients who fit the demographic of 55 to 74 years of age, had a 30-pack year smoking history, and had not quit within 15 years, were randomized to either get an annual low-dose CAT scan or a chest x-ray. And if a nodule was identified, it was worked up, and these patients were followed for about 6 years. This is just a slide showing the centers that were involved in this trial, and it's some of the major medical centers in the country, the Brigham and Women's Hospital, Johns Hopkins, a Jewish hospital, and a number of others, and that's where the number of 53,000 comes from. The one weakness of this study is when a nodule is identified in the CAT scan, there was really no unifying protocol for how do you follow it up. Currently, there are guidelines, but that's something that's been developed, and so that is a weakness of the study. But what this study found is that when they took a CAT scan of a patient at time 0, 1 year after, and time 2 year after, they identified a certain subset of patients who had lung nodules that underwent a workup. And when they did compare that to chest x-ray, they found that there was a fairly high incidence of lung cancer, particularly in the CT group. I think these two diagrams here are probably the most telling. These are survival curves from lung cancer right down here. And you see that as you start to work your way out to about 6 years, the lines start to spread out. So if patients underwent a low-dose CT scan and were identified to have a lung nodule that was identified to be cancer and they end up getting treated, versus patients who nodules were missed on, there was a survival difference, about 20%. This was confirmed in a recent study, just I think a couple months ago, but it was a European study, a smaller study of about 15,000 patients, took place in the Netherlands and Belgium, and it was similar criteria to be included in this. And this study was a little bit better because they had protocols for how you would follow these nodules. And I think the the most important part of this study was a 10-year follow-up. There was a 26 reduction in death from lung cancer. And so people have used this, are using this data to drive the decision to get a CT scan. Excuse me, and it's working. At Baylor Plano, there's a lung cancer screening program, and it's been around for about 4 years, and there's about 100 cases that present per year. Charlotte is the nurse navigator in charge of the program. There's a contact phone number that people can go to. They call Charlotte and get her directly, and then they go on to their CAT scan, and we follow NCCN guideline protocols for follow-up.
Thanks, Dr. Jett. Thanks, Dr. Waters. And thanks in advance for Dr. Kovoor. Thank you all for having me here. My name is Dr. Awad. I'm a pulmonologist. My part is talking about staging of lung cancer. I'm going to be honest. When we're trying to talk about staging of lung cancer, I have to open the slides that Dr. Jett showed us, and I get confused for about 15 minutes, and then we try to come up with a plan. So staging of lung cancer has gotten more and more complicated by looking at the size of the tumor, how many lymph nodes are involved, what is also involved, and it requires a thorough review every time we get a new case. So I'm not going to talk about that complexity. I can't keep up with that complexity, and it changed actually this year again. And it matters, like Dr. Kovoor is going to show us, because treatment is stage dependent. So it does matter that we get the staging right. But I'm going to talk about the generalities of the staging. Before I do that, there are a lot of nice graphs here. All of them were obtained from the internet, from thoracicfoundation.org. It's a great resource for patients and physicians. Just a simple idea. This is a tumor. You have lymph nodes around the windpipe, and the tumor you see on the CT scan right there is the big tumor you see on the image right here. So 5 facts, Dr. Jett already have mentioned them. Lung cancer is not one type of cancer. It is 4 different types, and if you add carcinoids, 5 different types. It is, however, divided into 2 categories. Small cell lung cancer has its own treatment and own staging system, and it's about 15 to 20%, 10% some studies. Non-small lung cancer, which encompasses the other 3, is what we're covering today. Unfortunately, many people are not treated. A lot of people are discovered in an advanced stage. There is a lot of, there are misconceptions now. They were not 15, 20 years ago. 15, 20 years ago, we had much more limited treatment options. A lot of patients were basically told, you have a lot of toxic chemotherapy, you're not going to do well, it's too late, consider palliative approach. That has changed over the years, as Dr. Kovoor is going to show us. We have better treatments, we have more effective treatments, we have more tolerable treatments, we have more specific treatments to specific types of cancer, which actually brings us to number 3. We have new options, mostly driven by the genetic studies. We look at the DNA of those cancer cells and we find new targets to treat. It can affect anyone. Again, those are a summary of the numbers that Dr. Jett showed us. More than 40,000 patients who are living with lung cancer have never smoked. We keep mentioning smoking as the risk factor, and it is the highest risk factor, but even radon exposure, which can accumulate in a poorly ventilated house and stays there for years, could increase your risk of lung cancer. More women die from lung cancer than breast, ovarian, and uterine cancer combined. It is more common in patients over the age, or people over the age of 45, but it can affect anyone. Early diagnosis is important. That's why, fortunately, we have more effective screening tests. We had lousy screening tests in the past, and they never made a difference, but now we do, and hopefully in the future we're going to even have better screening tests. It accounts for more than 25% of all deaths, although it is about 25% of all commonly diagnosed cancers. In men, it kills more people than prostate and colon cancers combined, whether primary smoking or secondhand smoking. 10% of males never smoked, 20% of females who have lung cancer never smoked. The symptoms Dr. Jett already talked about them, and 25% of the patients who have no symptoms just discovered on a CT scan, either a screening CT scan, or you go to the emergency room for kidney pain, and then they find a nodule at the bottom of the lung, or you go with a neck pain, and they find a nodule at the top of the lung. And among all common cancers, it have the lowest 5-year survival rate. If you catch it early, you have much better odds of survival. That's why Dr. Waters presented lung cancer screening. I'm just going to very briefly talk about what tests we have to confirm that you have cancer. We see a nodule on the CT scan. We see fluid around the lungs. What are the things we do? As a pulmonologist, I pass a small scope down the windpipe. The thing you're seeing right there, there is supposed to be a laser here, right here. This is called a forceps. We take bites of lung tissue. Well, it's not new. It's been there for 10 plus years, but its amazing addition is the utilization of ultrasound during bronchoscopy. If you remember the first slide I showed you with all the lymph nodes around the windpipes, now we can see them using the baby technology that we look at pregnant women and look at those beautiful babies. Using that same technology, now we can look at lymph nodes and actually stick a needle in them, sparing a lot of patients more invasive surgical procedures. Fine aspiration, this is usually done by our colleagues in interventional radiology, either an ultrasound or a CT scan. You localize the nodule, you localize the tumor, and then you stick a needle in it. Or you could stick what we call a core needle, which is a bigger needle, so you get more tissue for more studying. I'm not going to talk about this. I'm going to leave it to Dr. Jett. One more thing is that sometimes we're not getting a biopsy of the lung. We're not sticking a needle in the lung. Sometimes there's water around the lung, a condition called pleural effusion. So we stick a needle into the fluid, and we drain the fluid, and we spin it, and we analyze the cells in it, documenting cancer. So I'm just going to talk about each line of those. No, I'm not going to talk about any of this. This is basically lung cancer staging. As you could see, it is complex. It's divided into A's and B's and invasive and central and satellite. And it's getting more and more complex. And it has to become more and more complex because we need to get more and more specific. But it's so complicated that now we need a calculator for it. So this is a link for the calculator. If we can just show everybody. Let's go back and click on the calculator. They promised me it's going to work. Well, it's supposed to take us to a website that has a calculator that it's a drop-down menu, and it shows basically you say what the size of the tumor, how many lymph nodes are involved, and then you get the staging. Here we go. So you got the calculator there. If you select a T, an N, an M, you get a stage. You could view the details. You do reviews. All of those are hyperlinks. All of them are clickable for more information. So this is staginglungcancer.org. Thank you. We can go back to the slides. I'm just going to be very general in the way I'm going to talk about lung staging. Okay, stage one. Stage one simply is having one tumor in the lung. No lymph nodes involved, no tumor deposits outside of the lung. So this is stage one, simply. Stage two is when you start having the lymph nodes that are the closest to the tumor involved with tumor cells. Lymph nodes are immune system organs. Your tonsils that keep getting swollen when you were a kid, or in your kids or your grandkids, those are lymph nodes. Basically, their job is to trap abnormal organisms, abnormal cells, and react to them. So we are made to have draining lymphatic system and then lymph nodes around them in order to fight either abnormal cells, cancer cells, or foreign organisms. That's why lymph nodes get swollen, because they trap tumor cells They try to kill tumor cells, but unfortunately, more often than that doesn't work. We are trying to modify the immune system to kill tumor cells successfully, actually, but they get to swell. So when they swell closest to the tumor, it's stage 1. When they swell, I'm struggling with this. When they swell around the windpipe, it changes your stage to stage 3A if it is the same side, 3B if it's the opposite side, and that's very important because stage 3A, we could still treat it much more aggressively than we can stage 3B. And if the tumor leaves the lungs and the lymph nodes in the lungs ends up in the liver, in the brain, in the bone, anywhere outside of the lungs, or in the opposite lung, it becomes stage 4, and the treatment for that changes. This is called a mediastinoscope. I don't know how to use it. This is between Dr. Jett and Dr. Waters. As we said, staging depends on biopsies of lymph nodes. So we need to get access to those lymph nodes. We've always, as pulmonologists, been able to stick needles in some of those lymph nodes. But we had to do it blindly, using markers. So we did it only for specific lymph nodes, and we've only done it when they were really big. When they're not big, or they're close to the heart, or they're close to the blood vessels, we could not reach them as pulmonologists, so we would ask our colleagues from surgery to do a mediastinoscopy. What they would do, they would cut an incision, like where they do a thyroid surgery, and pass the scope, and then get big pieces of lymph nodes. And it's a great procedure, and we still do it. But not everybody needs it because technology advances. The most important advancement in technology for staging of lymph nodes for us pulmonologists is adding an ultrasound probe to the top of the traditional scope. So this is a balloon. We fill it with water because water moves sound waves. And this is a needle that comes out of the scope, goes through the windpipe into the lymph node, and then we can get small pieces of the lymph node, sparing good portion of patients a more invasive procedure. Sometimes we find out that the stage is too advanced for surgery, so we don't need to cut the lung of a patient, expose them to the risks and complications of surgery if the surgery isn't going to impact their outcomes. Sometimes we find something else that is not cancer, which is always a great news to give to a patient. Sometimes we still need to do the mediastinoscopy, but we have another tool to try to minimize the risk of procedures and end up with less invasive procedures. This is an ultrasound image of a lymph node, and this is the needle into the lymph node. This is how it looks on the screen when we're doing an endobronchial ultrasound, doing a fine needle aspirate. We talked about, Dr. Jett talked about the multidisciplinary clinic. In each program, every lung cancer patient will have either all or most of this group. And each lung cancer patient and their family needs to get to meet this group. Their primary care doctor, more often than not, is the one who ordered the chest x-ray or the CT scan or referred the patient for coughing up blood or unresolved cough. The pulmonologist, more often than not, I am the first point of contact. Cough doesn't go away, coughing up blood or sputum mixed with the blood, seeing a nodule on the CT scan, they get to refer the patient to me. The pathologist who reads the slides, the tissue we obtain from the patient. The oncologist and the surgeon and the radiation oncologist who treat the patient in combination with the pulmonologist. The only person that is actually not treating the cancer is me and the pathologist. But we are still part of the team because we're usually the point of contact and we're usually the part of the team that treats the cough and the shortness of breath and assists the other parts of the group with the side effects of chemotherapy and radiation.
So I'm Phil Kovoor. I'm one of the medical oncologists here. So I specialize in systemic therapies as they apply to lung cancer. So that can include chemotherapy, biologic therapies, targeted therapies, immunotherapy, and that keeps going and keeps expanding as the years go by. Lung cancer is a pretty big topic, so when they asked me to talk about treatments of lung cancer, I really had to kind of fine-tune how should I approach this. And so what I'm going to focus on what has had the most breakthroughs in the last decade. So I started here about a decade ago, and when I came, treatment for lung cancer was pretty simple. If you had a newly diagnosed patient with lung cancer, you did option one. If option one didn't work, you did option two. And if option three didn't work, then you thought about a clinical trial or palliative care. And so what I'm going to focus today on is about stage 4 non-small cell lung cancer. And stage 4 is about 40% of our newly diagnosed lung cancers. And as they mentioned, a lot of time our lung cancers are found either locally advanced or advanced at diagnosis. Stage 4 means that it is terminal, and we are doing treatments for palliation. In order to determine what you do for treatment, we've got to kind of understand where we were. And so just start off very briefly. So when I started about a decade ago, the median survival, if you did not do treatment, was about 6 months. And for traditional chemotherapy, the survival, depending on the study you were quoting, was somewhere between 10 to 12 months. And so we knew we had to do better. And so through a lot of effort and a lot of research, we found different biomarkers that helped us to determine treatment. So what are key factors in deciding therapy? So one, we look at an expression of a ligand called PDL1. That stands for Programmed Death Ligand Receptor 1. And if you overexpress this, you can qualify for immunotherapy. We also look at driver mutations. This includes EGFR, ALK, ROS1, and BRAF. And we look at histology. So histology means what we're seeing under the microscope, whether it's squamous cell or non-squamous cell. And to some degree, the extent of disease also affects what therapies we do. And so what I listed here is just a list of different targets. So the most common of these targets is EGFR, and there are 5 drugs that are approved currently. The preferred regimen by our national cancer guidelines is osimertinib. And the second target we look at is ALK, and that stands for Anaplastic Lymphoma Kinase Fusion Oncogene, and we won't say that again. And the preferred first-line therapy for that is alectinib. And we've got a few other drugs that I'll talk about, and this is almost in frequency. ROS1, we have crizotinib, and we have some drugs from BRAF that we've extrapolated from melanoma. And so this is just looking at the percentages of the mutations, and you can see that we've got a lot of different mutations. EGFR represents the bulk, and you've got ALK at about 3.8%, ROS1 is 2.8%, and BRAF is 2.1%. We've got a lot of other things we're still trying to learn about. So I'll start with what's considered the most common, and we've got a couple of mutations in these exons that we can identify. And so you have mutations that can confer sensitivity to our drugs, and the most common is exon 19. And then you have some mutations that can confer resistance, and the most common here is the T790M mutation. And so we'll start with osimertinib, and this is, so initially we've had some, and these drugs are called tyrosine kinase inhibitors. So that a landmark trial called FLORA that compared to our old drugs, gefitinib and erlotinib, and to this osimertinib. And basically, they took patients that had this EGFR sensitizing mutation, and they studied them to see how would patients do. And right here is just a picture of some characteristics. I kind of highlighted brain metastasis. So one thing we see in lung cancer has a predilection of going to the brain. And so it's an important part for us because we have a lot of limited options on what we can do. Brain metastasis, especially as we think about chemotherapy. So if you look here, we've got a progression-free survival curve, and the osimertinib was superior to our first generation TKIs. And we extended the progression-free survival by about 8 months. So it's about 18.9 months, where standard of care used to be about 10. And if you remember, we're talking about average survivals of about a year, and so this was pretty significant for us. And if we look at the different types of patients, age, sex, whether you had brain metastasis, everything favored the osimertinib. Now, I also just like to highlight the fact that those that had brain metastasis, this osimertinib had superior CNS penetration. So one of the barriers that we have in oncology is getting our drugs to get into the brain. The way God designed us, we have a blood-brain barrier, and it makes it very difficult for our drugs to pass, and we are finding solutions to that, which has been an important breakthrough. Also, the overall survival was improved, and for the osimertinib, we don't even have the final statistics on it yet, but the p-value was statistically significant, and so this has now become our first-line therapy now for EGFR types of cancer. So I'm going to move to the next target. This is ALK. Now, remember, this is not a frequent marker, but when you have it, it's something that we like because we can do a lot about it. And these are some of the markers that ALK targets. And so the drug that is considered the first-line drug for ALK-mutated lung cancers is alectinib. And the study that put this on the map was the ALEX study. And our prior drug that was our standard was crizotinib. And basically, this was comparing the old standard to the new generation drug. And what we found is that there was an improvement in progression-free survival. And the alectinib, actually, the statistics have not been met, and that's a good thing when you're looking at interim analysis. But the crizotinib, the progression-free survival is at 11 months. So this was statistically significant. If you look at brain metastases, it looked like the alectinib had better CNS penetration, and we were still getting responses. So those who had terminal diagnosis with brain mets, this was working. And we're looking at time to progression. So those who had pre-existing brain metastases that were treated, you could see the crizotinib progress at a higher rate than the alectinib. So this led to its approval in the first-line setting. So what happens when these drugs don't work? And so what's nice now is we've gotten a lot of different breakthroughs. So if the crizotinib, which was the usual standard, if you progressed on that, what do you do next? And we've got more options. Based on the ALTA study, we looked at basically crizotinib refractory lung cancers and looked at this drug called brigatinib. And they did 2 different doses to kind of figure out what was working the best. And what they found here is that the responses were prevalent, and that the higher dose, the 180 milligrams, was what was most effective. And it helped in overall survival and progression-free survival. And so based on this study, this drug got FDA approval as a result of that. And it also worked in patients that had brain metastasis. And so we're getting more and more drugs now that are starting to cross the blood-brain barrier. When I started here, I'll tell you, when we had patients with brain metastasis, we used to quote 6 to 12 months, no matter what we did. Whether it was radiation, whether it was surgery. These studies are showing that we're increasing those numbers, and we're doubling and tripling it in some cases. So if the second drug didn't work, do we have anything else we can try? And they came out on this particular study looking at a drug called lorlatinib. And what was interesting about this is they studied treatment-naive patients who had the crizotinib, and patients who had multiple TKIs. And what they found was that they saw shrinkage in all arms. So even if they had 2 to 3 different drugs versus 1 drug or a new drug, that this treatment was working. And it happened in patients that had multiple TKIs. And so this was important because now we not only have 1 drug, not 2 drugs, but 3 drugs for patients that have ALK mutations. And this is improving survival, again, 2 to 3-fold than what we used to do. And so I'm back to this chart again, and just ROS1 is only 2% of patients. This is just a diagram of what ROS1 is. And not all ALK inhibitors will actually inhibit ROS1. And so they look molecularly very similar, but we only have 1 drug that's FDA approved right now for ROS1, and that's crizotinib. Lorlatinib was also studied for this as well. I think in the future this will come out, and we've got a few other drugs that are in the pipeline, which again makes this exciting. Now BRAF is 2% of our patients, and this is what BRAF looks like. And so BRAF was initially studied with melanoma. And when this came out, we were making some pretty significant improvements in survival. And so in Lancet, they came out first studying dabrafenib in lung cancer and BRAF and found an improvement. And then they said, well, if it works for melanoma, let's try combining dabrafenib with trametinib, and it improved our statistics. And these are the different cohorts, which I'll skip by, but I just kind of want to point out that the median survival there was 24 months. So we're going from 6 to 12 months to 24 months with one line of therapy, which is a pretty significant improvement in the lung cancer world. So that's targeted therapy. I'm going to wrap up with immunotherapy. We see a lot of the commercials on immunotherapy in there. And it's been interesting. The last 6 months to a year, we've had more publications in the New England Journal of Medicine in lung cancer than I could recall in the last 10. And so I'll start off with Keynote, and this is for non-squamous cell lung cancer. And typically what we would do for non-squamous cell lung cancer in the metastatic setting is we'll do a platinum with pemetrexed. And so what they were looking at is, can we combine immune therapy, so therapy that revs up your immune system to help you fight cancer, and can we improve statistics? And what we see is a pretty significant change in survival. At 12 months, which is the median for prior chemotherapy, we're at 70% were alive versus traditional chemotherapy where it's less than half. And this was just published in April, and I believe this will be our new standard of how we approach non-small cell. And this is just more on progression-free survival, but I'll move to Keynote 407, and this was squamous cell. And again, this was just published right before Thanksgiving, which I was a little excited about that as I was putting this talk together. And it improved median survival up to almost 16 months compared to 11 months with traditional chemo. And so this, I believe, will be a new paradigm for us using pembrolizumab immune therapy in combination with a taxane and a platinum. Now, this is just more progression-free survival, but last 2 more slides. Keynote 42 was looking at, the first thing I'd showed you was programmed death ligand receptor 1. And so this is a marker that we can use to discuss immunotherapy. And if you overexpress it, and you consider a high expressor if you're over 50%. So what they looked at this study is could this be a new standard looking at patients that have this high expression? And what they found is that the survival was statistically significant. So we're talking almost 2 years as opposed to the traditional year with traditional chemotherapy. So if you're a high expressor for lung cancer, this is now the new standard using pembrolizumab or immunotherapy up front. And the last thing, most of this talk has been non-small cell lung cancer. Came out in September of 2018. For small cell lung cancer, it's highly associated with smoking, very lethal. We've been doing the same chemotherapy for about the last decade, and we finally have found something that's improved our traditional standard. Now, this was combining chemotherapy with immunotherapy, a drug called Tecentriq, and we had a little bit over 2-month improvement in survival. Standard survival 10 months, and this went up to 12 months. This will be our new standard, I think, coming into 2019, how we approach extensive stage small cell. And just a little bit of a cartoon here on nicotine patches, and that is the end of my talk.
All right, thank you, Dr. Kovoor. And just to wind up, I'm going to talk about the surgical treatment of lung cancer. Same disclosures. And basically, we're going to focus on the minimally invasive techniques for lung cancer. You have different techniques, and the maximally invasive is when you make an incision, spread the ribs. That's a thoracotomy. Minimally invasive is video-assisted thoracic surgery, VATS, or the Da Vinci robot. And we're heavy on the Da Vinci here. As you can tell in the lobby, we've got a robot in there. The various techniques, the posterior lateral thoracotomy really came in vogue in the 40s during the war. Initially, when you had an infected lung due to some object being retained, they would just open it up and drain it to the outside. Very deforming, but effective. They started doing thoracotomies and had superior results. As we progressed for lung surgery or chest surgery, we started making smaller incisions, trying to spare the muscles, but still spreading the ribs. We then converted to video-assisted with the video camera, and then robotic-assisted really came in the 2000s, really 2010 when it really got more accepted. For thoracotomy, the majority of cases are still done with a thoracotomy. It's gone down from 70% now, but this is what it looks like. This is a schematic, and that's the real thing. It's a good thing this wasn't after lunch. This is video assisted, and that's where you have a utility incision. You put a scope in, and it's a good way to do it, but the camera that you have is two-dimensional, not three-dimensional, so you have no depth perception, and it's still a little rib spreading when you take the specimen out. This is the robot, and we'll talk about the robot in more detail. And really, Dr. Daluski reported his results, and that really was the advent of widespread use of the dementia robot. My experience with the robot dated back to 1999, 2000, when I was chief at Providence Seattle Medical Center, and we had two robots. The robot was invented for the field military to care for the wounded soldier remotely. The first clinical extrapolation or application was for cardiac surgery. And at that point, we were doing a lot of new things, minimally invasive valve, beating heart surgery, and everybody jumped on board, yet few people continued with it because it was very difficult, too many variables. You had Da Vinci, which is what we have now, but you also had Zeus. Zeus was counterintuitive. Essentially, it was robotic VATS. And when I was at Seattle, we had Zeus. We had a couple of clinical cases, and it was absolutely miserable. This is what it looks like with it mounted on the bed. You weren't remote. We thought it was advantageous, but it really was not. You had a voice-activated camera, and the camera is called ESOPs. You'd go ESOPs in, ESOPs out, ESOPs up, ESOPs down, and ESOPs could never get a Texas accent down. You know, I'd say one thing, and it would do another thing. So Da Vinci won out because it had enabling technology. It's intuitive. It's three-dimensional vision, so you have depth perception. And it has an endo wrist, so it's like having little hands in there. It moves 7 different ways. When I left Providence Seattle Medical Center, I prayed that they would never perfect robotic surgery until I retired. Then that changed 2011. I saw Dr. Daluski doing a robotic lobectomy. At that point, I was 100% VATS, thought VATS was great, and I decided to convert, and we brought it here, starting our program in 2011. These are the components that you saw in the lobby. We have the latest version, which is the XI. The older version is the SI. This is a little 2-minute or 30 or 40-second video. Hopefully that we can get this. I am Kimble Jett. I'm the medical director of thoracic robotics at the Heart Hospital Baylor Plano. The Heart Hospital Baylor Plano is a full-service, freestanding cardiac, thoracic, and vascular surgery hospital.
This is robotic-assisted cardiothoracic surgery. This is the robot. The robot has 4 arms that can reach over, 1 for the camera and 3 arms to do various maneuvers on the part or the lungs. These are the instruments that go into the robot, and they have an endo wrist, which will move 7 different degrees of freedom like a normal wrist. This is the vision part where everybody can see what is going on, what the surgeon's doing. The patient is on the table, but the surgeon is at a remote site, 10, 15 feet away from the patient, operating the robot. I am sitting at the surgeon console, and this is where I would sit to perform an operation. Look into the monitor, begin to see a three-dimensional view of what's going on. And every limb that I have is operating some function of the robot. My 2 hands are operating the 2 instrument arms, but also my feet are down here working as well. I can operate, if I need to coagulate something, or I can operate the camera to move in or move out. I'm in complete control of everything that's inside the chest or the heart.
And that was a little segment that we did for Dallas Morning News on their website. Anyway, this is kind of what it looks like remotely over the patient. This is the robot docked on the patient. You have a bedside assistant and a scrub nurse. With robotic surgery, the clinical benefits to the patient are less trauma, faster recovery, and decreased morbidity and mortality. To the surgeons, you're providing the least invasive technique that's available. You have better visualization. Because of the better visualization and better lymph node dissection, it's a better comprehensive cancer operation. And that's been verified by Dr. Serfolio, had a recent publication over 1,300 robotic cases, and the survival was 10% greater for each stage versus the traditional techniques. So it's pretty good. Plus, as we are getting older, not Dr. Waters, but myself, we get to sit down, and it's ergonomics. I think it will lead to our career longevity. for better or worse. But anyway, our first 300 cases here on campus, a third of them are lobectomies, a third are just wedge resection for biopsies or benign nodules, anterior, posterior mediastinal masses, and other things like decortications. And there's not anything you can't do in the chest. You can do esophageal cancer, you can do lung cancer, so you can do everything. This was 116 of our lobectomies, and the average time was 167 minutes. Now, an average lobectomy for us is about 120 minutes, which is, pretty good. Average chest tube is 1.7 days, length of stay 2.7 days, 14% complications, and 1% mortality. 50% of our patients go home on the first day. 35% of our lobectomies go home the next day with no restrictions on their activity. And some people in the audience may even be able to comment on that they can have surgery on Tuesday, be in the gym by Friday. We have a very aggressive management of patients, but everybody's managed the same. So we compared our patients that had robotic surgery versus VATS versus open, and we're still about 2 days shorter than VATS. The national average is on the left at 7.4 days, and we're at 2.08 days. This is our STS database, and our length of stay is half of what the STS database is, and we're even less than what the national average is. And in that group of patients, we had no mortalities. We have the lowest length of stay in the state of Texas, which we're proud of. This is what our program did last year. The volumes were up. Thoracic was up 23%, but cardiac was up 59%. Last year we did 80 lobectomies. The definition of a high volume center is 20 lobectomies. So we did 4 times the definition of high volume. Our thoracic program has continued to grow with robotic surgery. Not everything is robotic chest. We also do cardiac, but also the cath lab is using the robot as well to get the operating cardiologist away from the radiation. Last year, we had 1,000 combined cardiac and thoracic cases, which we were proud of, and we're featured in Plano Profile as Dr. Robot. I don't necessarily like the one on the left, but Dr. Robot's good. Robotic surgery is increasing. 2014 is up to 16%, 15 is 19%, and last year is up to 30%, so it's starting to catch on. These are some of the more recent data looking at robotic surgery. This is Dr. O, 2017, looking at the Premier Healthcare Database, over 28,000 patients, and they matched robot versus a thoracotomy or open, and they matched the robot versus VATS. And what he found was that the robot was better than VATS, but then when I put my lobectomies in there, our complications were less, mortality is less, length of stay was less, and our operative times were less. This is the most recent article from last month from Dr. Reedy, who's at the University of Michigan. Similar study, except they wanted to look at experienced robotic surgeons, and an experienced robotic surgeon is one that does greater than 20 cases a year. And again, they matched robot versus VATS, found that the robot was better, but then we put our data in there, and the campus program looks pretty good. This is Dr. Cerfolio's article that I talked about. And the purpose of this article is look at 5-year survival. One of the complaints against the VATS is that they felt like the 5-year survival was not equivalent to open. Same criticism has been against the robot, although as robotic surgeons, we thought it would be better because you get better lymph node dissection. And this is what he showed. With their 1,300 lobes compared to the 7th edition of the International Association for Study of Lung Cancer, it was like 10% higher in each stage. You may say, well, the robot's great, but it's expensive. So we look at the expense of our robotic lobectomies compared to VATS, compared to open, and we are saving anywhere from $4,000 to $7,000, but if you factor in the cost of the robot, we're still saving $3,000 to $6,000 over open. And this is what we look like. The blue is our data compared to VATS versus open. So we're saving money with the robot. When patients go home, there are no restrictions on activity. They can drive, go to the gym, do whatever they want to do. We do encourage them to bathe daily, to breathe, breathing exercise 4 times daily, avoid constipation, pulmonary rehab if available, and return to clinic in a couple of weeks. This is a robot patient just a couple of weeks post-op. Robotic surgery is the fastest growing procedure volume for robotic operations. There's a low cancer recurrence and mortality in advanced stages, minimal pain, including postoperative neuralgia, less blood loss, fewer complications, faster recovery of your lung function, shorter hospital stay, faster overall recovery, better lymph node dissection, and important for the rest of the panel is that if somebody does need some adjuvant postoperative therapy, whether it's chemo or radiation, there's no delay. If you have a thoracotomy, you delay 4 to 6 weeks. With robotic surgery, you can have it the next week. We had one patient that actually was a nurse on our campus who came in with a headache, found to have a brain met, and also a left lower lobe lung lesion. So she started radiation therapy on a Monday. On Friday, she got radiation therapy. We did a lobectomy. She went home Sunday and continued her radiation therapy on Monday. So there's no interruption in whatever treatment that they need. So in summary, for the surgical treatment, chest robotic treatment of lung cancer, there's great patient, surgeon, and hospital benefits. It is cost effective with reduced length of stay and complications. Importantly, you don't need to travel elsewhere to get your treatment, whether that's going to be surgical or whether it's going to be radiation or medical oncology or whether it's going to be pulmonology. Our campus offers a full spectrum of treatment. The Heart Hospital is the busiest in the Southwest for robotic surgery, and we're 7th in the world in terms of robotic volume. We, in addition, are a worldwide observation center. So early detection of lung cancer is critical for survival, as has been stated up here. Staging of lung cancer is critical for its treatment. New modalities are available, in particular the targeted treatment. And importantly, Baylor Scott and White Plano offers a multidisciplinary cancer treatment program. And again, to emphasize, you don't need to travel. And just to wind up with 2 slides, this is a robot patient that we did that's 2 weeks post-op, and she loves the garden, wanted to get back to the garden, so she's able to get back to her garden. And I like this slide because to our left, her right is a tiller. And I don't really think she is using that tiller, but it makes for a real good picture. We do outreach programs where we go to some independent or assisted living. And this was one that we did, and this was one of the residents, Buddy. And Buddy was great. He is 104 years old, and it proved that you're never too old to do robotic surgery. I'm not that old, but you're never too old to do it. And we asked Buddy, he said, Buddy, how'd you get to 104? And he thought for a minute, he says, getting to 103. We thought that was a pretty darn good answer. So anyway, we'll entertain some questions and answers. I'd like to thank our panel for their excellent presentations and sacrificing their time to help educate all of y'all. And we'll answer whatever questions that you have. And we thank you for coming. We really appreciate the opportunity to present our program to you.
So a couple things. You're asking a question that we ask a lot, which is, how does someone metastasize? Whether it's the brain or some other area. And traditional thought is that when they had the original diagnosis, likely a seed of cancer metastasis. What I'll tell patients in my office commonly is I've got over 1 million cells in my hand. I can't see it. So I take a scraping and put it under the microscope and see how much stuff is there. So what goes underappreciated on PET scans, MRIs, is our resolution to see things. If you look at the makers of PET scan, they say about a centimeter. In reality, in clinical practice, we could see reliably at about a 5 millimeters. And sometimes we can see things that are a little bit smaller than that. But a lot of our major modalities, PET, CTs, and MRIs, have a resolution limitation. So there can be something there that we just can't see. So likely what's happened is you had a seed of cancer. Likely during that time, I suspect that your immune system is controlling it. And as you move further enough from your primary treatments, it gave enough time for it to mutate. The mutation would be defined as change. And when it changes, those are the drivers for growth. And so all of a sudden, an immune system that was controlling something, maybe keeping it at a microscopic level, now is beginning to grow. And so I think likely it probably was there, just probably was not able to detect it with the correct technology. So I'll comment on that piece, which is you would be an outlier for most patients. So if you talk about traditional brain cancer with metastasis from lung, it's about a 12-month median survival. Really good scenarios if you've got a driver mutation, some of the slides I've shown. I've got patients in my practice that can go out to 3 years, on 2 to 3 years on average. But if you're going to talk about patients that have made it 5 years in a scenario like that, it's less than 5%. So sometimes we don't have explanations for that, but I'll say that's good old-fashioned divine intervention. I agree.
And just a little plug, next day. Yeah.
Only if we get to choose, right? Only if we get to choose when we get sick and when we don't get sick.
But, that's what this is all about, our survivors. And like I mentioned early on, there are over 400,000 lung cancer survivors, and that's what we're trying to do, is to not only ease the treatment, but improve survival. And this is Lung Cancer Awareness Month. The little white ribbon cookies, or white ribbon, is lung cancer awareness. We have little bracelets out there, Survivor Strong. So this is for all the survivors out there. So help yourself to grab one or two or whatever.
I have a quick question.
Go ahead.
Hold it. Okay. Do you think that they'll ever think about adding to the screening criteria for people that have been exposed to hands for numerous years, like, I don't know, your entire childhood up until you graduate and leave the house? And then do you think they'll ever add that? No other symptoms or anything, but just simply secondhand smoke?
I'd like to take that question if it's okay.
Sure, it's all yours.
So we screen by CT scans. They're low-dose CT scans, but they're CT scans. So there is a radiation there. So unfortunately, like everything in medicine, and we're getting better, and I'm one of those people who are very optimistic that we're going to start screening cells when we screen you for your blood pressure by a blood cell, hopefully sooner than later. But as of now, we screen by radiation. Radiation, as it accumulates, can increase the risk of cancers. So it's a pretty fine balance. So right now, we're screening the highest risk patients, and even in those patients, despite we are making a difference, when you look at the overall data, it's not, most of the people who are screened don't have cancer. Only 1 or 2% of the people who are screened have cancer. 20% of the people who we screen will have an abnormality, and only 1 out of those 20, that abnormality is cancer. Actually, 5% of we screen have cancer. So we're finding things, we're scaring people out of things. Sometimes we're doing biopsies and bronchoscopies for patients. If we screen more patients who are lower risk, we're going to find more incidental findings that are going to be benign. So it's a fine balance. It's definitely a moving target. Maybe in 5 years, we'll have a completely better screening program than low-dose CT scan. Maybe we can get away with, as the resolution in CT scans gets better, maybe the radiation risk becomes significantly less and the resolution better, and then and we have better criteria for deciding which lesion to biopsy and which lesion not to biopsy, then it could be worth it. But as of now, screening more and more people who are low risk is not the answer, not yet.
Yeah, that's what the guideline is. That's right.
So there are caveats there. So 55 to 74, 30-pack year, and it looks like the European study has actually less stringent smoking requirement than that. But there is also more guidelines. there is this need to explain to the patient what the patient is going to be getting into, how they're going to approach what we find. Most of the time, it's not going to be malignant. Some of the guidelines also recommend not to screen people who are not candidates for surgical therapy, because finding a patient with very advanced COPD and a pretty bad emphysema, finding that they have cancer and then not being able to act on it or acting on it will increase the illness of this patient is also a concern. So there are a little bit more criteria to that. Most importantly, it becomes the discussion between the patient and the physician. But yeah, the broad strokes, the broad brushes are what Dr. Waters presented.
And they're all just guidelines. They also say that if you smoked you have to have smoked within the last 15 years. So if you quit 15 years ago or 16 years ago, you're not within the guidelines. Saw a patient in the office today who has a lung cancer, quit 38 years ago.
Yeah. As we presented, 10% of men, 20% of women never smoked. We're talking about 30%, 25% of patients who don't even qualify for screening. And that's why we need, and hopefully we'll get to, better screening techniques. X-ray is a very lousy way. X-ray has, when people looked at X-rays and sputum cytology for years. They even looked at CT scan for years. Before the new generation of high-resolution CT scans, they were not a good screening tests. If there is anything we want to convey in this panel is the future is going to be better than the present. We are making massive strides, both by screening, by early diagnosis, by effective surgical treatment, by minimally invasive diagnostic techniques, and by more personalized medical treatments.
We don't have, so when we look at analyze that, what you're asking is the rate of metastasis of other cancer sites to the lung versus just standard lung cancers. Well, if you look at the statistics that they show in the slides initially, lung cancer is one of the second most common diagnoses in the U.S. Globally. It's at a pretty high rate as well, especially with all the smoking that happened in years past. But we don't really necessarily have models that are telling us what percentage of people are metastatic to the lung per se, because we're looking at them in a little bit different lens, which is are you stage 4 or are you early stage? And whether you're a lung metastasis or some other metastasis, we're in stage 4, so that information doesn't change kind of our approach, contingent on the subtype of cancer. But in practice, and I've got a very varied practice, I see a lot of thoracic malignancies, but I also see a lot of cancer that metastasize into the lung. And we're doing better. So if we, for example, in colon cancer, or even something like soft tissue sarcoma, if we've got an isolated metastasis in the lung, we can talk to either our surgical colleagues to the right or our radiation oncologists and do combinations of surgery and or chemotherapy and radiation, and have patients that have nice disease-free intervals or even in some cases going into remission.
Yeah,
Most cancers you find in the lungs are of lung primary. They're not from somewhere else. The number, and don't quote me because I might be wrong, because the number when I was in fellowship was 80% of masses in the lungs are actually of lung primary, 20 came from somewhere else, but that was before we started even finding smaller lungs, so that number is probably lower now. But it was 20/80, 15 plus years ago.
Yeah, surgical treatment is different, whether it's primary lung cancer versus metastasis. The goal of surgery for primary lung cancer is to take out the segment or the lobe of the lung and all the lymph nodes, because when lung cancer spreads, it goes through the lobe to the lymph nodes out to the body. Taking the lymph nodes will capture that, but also allow you to stage it. If it has come from elsewhere, then it didn't come through the lymph nodes, it came through the bloodstream. So our goal for surgery then is just to remove the mass or the cancer itself with a wide margin. And that's why, in that circumstance, stereotactic radiotherapy may be as effective as surgery, but we don't remove the whole lobe or the segment typically for metastatic lung cancer.
So one of the last two studies, for the high PD-L1 expression for pembrolizumab, that was Keytruda. And so that's first-line indication for high expressors of PD-L1. You can, Opdivo or nivolumab has more of an open label. You don't have to look at the PD-L1 expression, but it's not first-line. So traditionally, in those particular patients that are not high expressors, you will use traditional chemotherapy and then come back to either something like Keytruda or Opdivo. For the interest of time, I was trying to keep it as concise as I could, but this topic is extremely complex with a lot of different publications that have come out in the last 5 years. Immunotherapy has been a game breaker in the cancer world, not even just in lung cancer. Because if you look at the clinical studies, we didn't really have as many age limitations. So you have patients in their 80s and 90s that can receive immunotherapy if they're appropriate for it. In years past, if you had someone that was over the age of 85, there probably wasn't a lot of great options that we could offer. And so that's changed the landscape. As we're getting more older patients that are being diagnosed with cancer, we have more options than we did with traditional chemo. But it's not the solution. So meaning that I always get asked, is this the magic bullet? Because a lot of the TV programs and things that you'll see on CNN and make you kind of think that, oh, we've got a cure on the horizon and I'll get neighbors and friends, oh, are we there? No, we're far from it. So when I first was in medical school, I attended an oncology lecture, and I remember they had a pathway lecture, and there was only a few little spots of the different type of mutations. And maybe about 10 years later, that slide got pretty significantly worse. And then maybe about 5 years ago, I looked at that same type of slide. It looked like someone threw an atom bomb on the slide. There's so many different pathways. What we're learning is we're scratching the surface more and more, but there's more to learn. And when we think we've identified a pathway, there's a pathway within a pathway. There's something else that's promoting that pathway, and we're finding different ways to do it. So we don't have a magic bullet yet, but I think it's just continuing to help us to understand how complex it is. And I think we're getting better, and we're on the right track. We're getting better technologies to help us to identify what those markers are. So that's something in Texas Oncology that and especially here on this campus, that we're really trying to do is increase our research initiative on campus so we can make those breakthroughs for tomorrow. So what we're doing on campus right now is we have phase 2 and phase 3 clinical studies. Likely by the summer of 2019, we'll probably introduce some phase 1 clinical studies. And we're a community program, a very high-functioning community program. You won't find too many community programs that have phase 1, phase 2, and phase 3 clinical studies and initiatives on campus. But we're passionate about it. We're passionate for that very reason of how can we make those differences for tomorrow? So as our kids and grandkids get older, that they have better solutions to the problems that plague us today.
Kind of speaking to that about the future, I do, in some of the articles I read, I do see that cigarette smoking is decreasing, but in the youth, vaping is increasing. And so I was wondering, how much do we know about the risk of vaping when these young adults feel as though it's safer than regular cigarette smoking?
We don't mean, we're still confused about vaping. Some studies tell you it's a great way to quit smoking, as recent as 2 weeks ago. What we know about the youth, if we're going to put active smokers aside, what we know about the youth is that Vaping has an amazing advertisement machine behind it. It's pushing very hard. It's colorful, it's hip, it's cool, it's electronic, it's battery operated, and I don't know if they connect to your iPhone with a Bluetooth or not. But we know that adolescents and young adults who vape do smoke more. They end up smoking more. That has been validated over and over and over. I have the same mantra I tell my patients: if it's not clean air, you don't need it in your lungs. I mean, period. When it comes to marijuana, my feelings and the legality of it aside, I tell my patients, eat it, don't smoke it. Because you cannot tell me that burning things are not gonna hurt your lungs. I mean, and I think whether it's in environmental pollution, whether it's radiation, whether it's radon, whether it's vape, whether it's even those essential oils that some people inhale, I really think all of those eventually are going to lead to problems. So my message is, if it's not clean air, you don't need it into your lungs.
Well, I just want to add one thing to that, I have a feeling in the next 10 to 15 years, we're going to have a better understanding of what vaping does. But there's some people in this audience that are old enough to remember thalidomide. But, we used to give thalidomide and then found out all sorts of problems with thalidomide. And as we get wiser, we learn what these things are doing. And, I tell patients, just be as clean as you can. Because, I think we're learning more and more about what are carcinogenic, and I get the question of, should I use deodorant? Well, I sweat a lot, so I need deodorant. Point being is we have to have good sense. Certainly smoking and vaping, I don't advocate. But things, even the natural things, and we've got a lot of natural paths in Plano, I would say. But I had a patient that took a green barley supplement. And I'm telling you, this was a God thing, because I don't usually repeat the labs if I saw someone 10 days before and they didn't do any chemotherapy, but I'm telling you, I just had a bad feeling. And so I checked labs, and right before I'm starting chemotherapy, and this guy was in florid liver failure. And then I had to do a strong history and found out he took this supplement because somebody said, hey, take this will help you. And I'll tell you, if I didn't do that, a week later when he came in for the repeat labs, I would have blamed everything on chemotherapy. This seems something that's very innocent that a lot of people do, but I found case reports of liver failure. And so, when we do these hyper-concentrated doses of natural remedies, I'm also cautious with that. And so I think alternative medicine and mainstream medicine can synergize. We just need to know what's going on. And I tell patients, we can't tell you for sure, is it going to interact or it's going to cause these side effects. I'll tell you, if we get some unusual side effects that are not typically package insert side effects, first thing to go are going to be the supplements. So it can kind of, yeah, exactly. So and his was curable at the time of his diagnosis, which was, another topic of conversation for another day. But I think we just have to be wise in it. But there are merits to it. Taxanes that I've showed you, that originated from a plant in China. And there were medicinal value to that years ago, centuries ago, and we found out it has anti-cancer activity. My mom's a little bit of an alternative person, and she'll give all these kind of things to my kids. And I'll tell you, there's some things that I've used on my kid's skin that I can't explain to you scientifically why it works, but it works, and I don't have to use steroids. I know there are merits to those things, and I think I try not to put blinders on that, but I think we've got to use good sense.
All right. Well, in consideration of your time, I think we'll bring this to a close. And again, we thank all of y'all for coming. The robot is still out there. If you haven't played on it yet, go play on it. You can get an appreciation of what we do in the operating room. Again, thanks for coming.